to my colleague.
Well, good afternoon. So it's a pleasure for me to announce the next speaker, who is Professor Felix Tanner, head of the echocardiography lab at the University Hospital of Zurich, who is going to give us a talk on the value of cardiac echo in differentiation of acute dyspnea. Felix, thank you very much.
Thank you, Mr. Chairman. Ladies and gentlemen, both talks you heard in this session mentioned echocardiography, so now it's time to focus on it. Acute dyspnea can have a variety of reasons, starting from disturbed neuromuscular regulation, disturbed transport of oxygen to the lungs, disturbed gas exchange in the lungs, disturbed cardiovascular regulation, disturbed transport of oxygen in the body, and other reasons. But since the title of this talk is the role of echocardiography, I will focus on cardiac reason for acute dyspnea. Now, acute dyspnea for cardiac reasons is always some sort of acute heart failure. And the new guidelines on heart failure emphasize that acute dyspnea can be caused by a primary cardiac dysfunction as well as by extrinsic precipitating factors. And evidently, you can have an acute heart failure as a primary event or occurring on top of chronic heart disease. The new guidelines distinguish three forms of chronic heart failure, and all of these three forms can show acute exacerbations with acute dyspnea. They distinguish between the heart failure with reduced ejection fraction, that's an ejection fraction below 40%. Mid-range ejection fraction is between 40 and 50%, and preserved ejection fraction is above 50%. Now, time will show how reasonable this distinction is. At the moment, we just have to live with it. But important is that the distinction between these different forms of heart failure is done by echocardiography. The most important reasons for acute dyspnea for cardiac reasons are an acute coronary syndrome, an excessive systolic blood pressure, cardiac arrhythmias, both too high or too low heart rate, or then acute mechanical causes such as aortic dissection or pulmonary embolism. So in the process of diagnosing these entities for acute dyspnea, when does echocardiography come into play? This is also a schematic from the new guidelines on heart failure. And I think this is a very nice overview of how we should deal with a patient arriving at the hospital with acute dyspnea. So once we suspect dyspnea for acute heart failure, there is a distinguish between an urgent phase within the first minutes and an immediate phase within the first 2 hours or so. And the basic questions to be answered in this urgent phase is there a cardiogenic shock? In that case, we should provide circulatory support. Or is there respiratory failure? In that case, we should provide ventilatory support. Now, once the patient is stabilized and lying on an ICU or another appropriate facility, the basic question is, what is the reason for this acute decompensation? And here, echocardiography certainly plays an important role in providing information on anatomy and function of the heart and helping with differential diagnosis. These guidelines do not only mention echocardiography, of course, and I would like to emphasize that that's trivial, but nowadays our younger colleagues sometimes tend to forget that. Clinical examination is, of course, the first thing to do, and laboratory assessment, ECG, eventually an X-ray, should be done before the echo. The guidelines mention in particular BNP in order to distinguish between cardiac and non-cardiac reasons for an acute decompensation. And then they recommend echocardiography. It should be done immediately in hemodynamically unstable patients and within 48 hours in all the other patients. In this study, we looked at, with Simon Stempfli, we looked at the role of BNP and echo, here depicted as ejection fraction, in the initial diagnosis when patients with a non-compaction cardiomyopathy present in the hospital. And this study showed that the BNP and the left ventricular ejection fraction determined by echo have a comparable usefulness here in order to predict death or cardiac transplantation. Every doubling of BNP and every decrease of ejection fraction by 10% go along with a hazard ratio of about 3. And when we do a collinearity analysis of the role of BNP and ejection fraction in this diagnostic process, then they are roughly comparable in their predictive value. Important is that when the BNP is normal and the ejection fraction is normal, cardiac reason for the acute decompensation is not probable. And this is in contrast to when the BNP is above 2,000 or the ejection fraction is below 30, then this goes along with a really high hazard ratio in these patients. Now, echocardiography has gone a long way in the last 40 years, from 1 to 2 and now to 3 dimensions. And in principle, in daily practice, we work with all 3 possibilities, but I will try to show you that each of these still has its value in daily clinical practice. What is frequently forgotten is that an echo, when it is carefully done, needs time. Because in the echo we look at basically everything we can in the heart, beginning by a structural analysis and continuing with the hemodynamic assessment, and finally by providing information on the etiology of heart failure. So let's look at an example now in the aortic valve area. This is a really revealing image because it tells you a long story. So this patient has a severe acute dyspnea. Why? Because the aortic valve here, this is a prosthesis, we see the artifacts, has detached in the posterior part. We have a rocking of the prosthesis. And this goes along with a severe acute aortic regurgitation, which causes a profound elevation of left ventricular filling pressure. You can see that because the mitral valve closes prematurely. And the reason for all that is that the patient suffers an endocarditis. So this is a nice example of an echo image which tells you a whole story and enables you to rapidly react in terms of treatment of this patient. Now, some of you probably smiled before when I was mentioning one-dimensional echo, that we still use it, but I was serious. And I tell our young fellows again and again that they shouldn't forget about it. I talk about the M mode, which is basically a linear measurement, so in one dimension. But you see that it still has a high value. This is again from the aortic valve region here, and you see that here there is this is a part of the leaflet of this prosthesis, which is depicted here by the M mode, and it has its own motion, independent of the motion of the rest of the cardiac structures. So this is fluttering. So this is a sign of a severe aortic regurgitation here, and can explain dyspnea in this patient, of course. And with two-dimensional echo, you can confirm that. This leaflet is prolapsing and fluttering because of the severe and very eccentric aortic regurgitation. Now let's look at a third example, again from the aortic valve region, but caused not by a process in the aortic valve, but by a process in the aorta, which exerts an effect on the aortic valve. So this is from a TOE. You see the proximal descending aorta. So the patient has suffered an acute aortic dissection. And this did not only cause pain, chest pain in this patient, but also acute dyspnea. I'll show you in the next slides why. So let's work our way back to the heart. This is an image of the aortic arch. You see that there is at least one, probably two dissection membranes here, suggesting very complicated anatomic situation. And when you look at the aortic root, you see that this dissection membrane prolapses through the aortic valve in the left ventricle. So you can say with this image, without any other method or hemodynamic assessment, that this patient suffers a severe acute aortic regurgitation, which again explains its acute dyspnea perfectly. I continue by showing you an example from the mitral valve area, because I would like to show you the value of the 3D echo in such an acute situation. That's also from a TOE. It is the surgical view of the mitral valve. Up here you have the aortic valve. So basically that's the view the surgeon has when he approaches this valve in the operation. So you see here that in the medial part of the valve there is something extremely wrong. And that's an advantage of the 3D. We can do with this volume whatever we want. So now we look from the side, and you can better appreciate that here there is a severe prolapse of this leaflet. And here you have a ruptured tendon. And at the end of this ruptured tendon, there is part of the papillary muscle head. And in this view, you can see that even better. So that's a classic flail leaflet, which is moving back and forth from the ventricle to the atrium. And the reason for it is a papillary muscle rupture leading to an acute severe mitral regurgitation and causing an acute dyspnea in this patient. So far I focused on valves, but of course we can also get important information on the function of the myocardium by the echo. That's a picture from the intensive ward. And this patient has suffered an extensive acute myocardial infarction, and you see that ejection fraction is really severely reduced. All this part of the myocardium is basically standing, is not contracting anymore. Only in the lateral basal part here there is a contraction. That's interesting, but it's getting even more interesting. So echo can be even have an entertaining aspect in such patients, apart from the individual drama here. You see that this patient suffers not only a systolic mitral regurgitation, which is this very short peak you see now, but also a diastolic mitral regurgitation, which is much more pronounced as the systolic one. And you can, with the color M mode, you can objectify this. The patient is still in sinus rhythm, and you see that this diastolic mitral regurgitation here in blue is transiently interrupted by the contraction of the left atrium. And you can quantify that by a spectral Doppler. Here with a continuous wave Doppler, you can see that there is this systolic and diastolic mitral regurgitation. So I show you to make this to make the point that echocardiography does not only provide anatomical and functional information, but also tells you a lot about hemodynamics in these patients. And what I should also mention, of course, is the pericardium. This patient suffers an acute tamponade due to a hemodynamically relevant pericardial effusion. You can see this here, that's the right ventricle and the right atrium, and both heart cavities are compressed by the pericardial effusion. There are a lot of reverberation artifacts here, which could not be eliminated, but anyway, we can see the shape of the heart here. And in this image, you can see the echocardiographic pendant of the pulsus paradoxus, namely that with each inspiration, the left ventricle becomes smaller and the right ventricle becomes bigger. That's expiration, inspiration, expiration, inspiration. So based on these images, this pericardial effusion was punctured, and afterwards you have a much lower heart rate and a normal shape of the right-sided cardiac cavities, and no dyspnea anymore. And sometimes, and now I was too impatient, sometimes echocardiography can also reveal the reason for the pericardial effusion, as in this patient here, where you see this tumor which has invaded the pericardial space and led to this problem. So in the last few minutes, I would like to mention acute pulmonary embolism and the role of echo in this context. I thought that particularly reasonable because probably more than 50% of the audience is from the pulmonary area. And I would like to focus on the new ESC guidelines on the pulmonary embolism here, which make the point, quite rightly so, that this is frequently a very difficult diagnosis, mainly because the clinical picture is extremely variable, ranging from asymptomatic patients to patients in shock. And of course, you have all the rest of symptoms in between. The most frequent is acute dyspnea, followed by chest pain, syncope, and others. So where does the role of echo lie in this particular situation? The guidelines distinguish between patients with high risk and patients with not high risk. Those with high risk are those with shock or hypotension. In this case, they recommend to do a CT angiography. That's the problem of the cardiologist. When he reads angiography, he thinks about coronary angiography, but of course that's wrong here. It's a CT angiography. Anyway, and based on that, you should treat or not treat. If that's not available, you should do an echo. And in the echo, you should primarily look at signs of right ventricular dilatation and or overload. And if that is given, you can, in this situation, even without a CT angiography, go for treatment, even invasive treatment. So echo is important in these high-risk patients, A normal right ventricular function more or less excludes pulmonary embolism as a cause for the hemodynamic instability and the acute dyspnea. But right ventricular dysfunction in these patients may justify to go for emergency reperfusion treatment without CT, if that's not available, or if there is no time. The picture is different in patients who are not in shock and not in hypotension. Those have a lower risk. And here we should go for a probability of pulmonary embolism. Different probability scores are recommended. This one here is the Geneva score. And based on these scores, when the patient has a low or intermediate clinical probability or a clinical judgment of the patient without a score, then we should do a D-dimers. If that's positive, treat. If it's negative, look for other reasons. And in those patients with a high clinical probability, we should do first a CT angiography. Echo can be done in these patients. It is not recommended for diagnosis in stable patients who are not at a high risk. That is very important. But on the other hand, echo can help in the prognostic assessment of these patients, because when you have a right ventricular dilatation or a right ventricular dysfunction or right ventricular thrombi, you have an increased early mortality in these patients. Early mortality meaning within the first 30 days. So this is a nice view of a four-chamber view of a patient with acute pulmonary embolism. And what you see here is the so-called McGonnell sign. This has been published by Mr. McGonnell quite a while ago. And the McGonnell sign means that you have a dysfunction of the right ventricle, mainly an akinesia of the mid-ventricular free wall, and maybe less pronounced, but still disturbed motion of the myocardium in the basal free wall. But the apex of the right ventricle has a maintained contractility. He analyzed that in his patients, this pattern here. That's the basal part, the mid-ventricular part, and the apical part of the free wall. And this can be easily distinguished by chronic right ventricular dysfunction, where we don't have this exaggerated contraction of the apex. Of course, this McGonnell sign is not specific for pulmonary embolism, because a patient who has suffered the right ventricular infarction can also have it. But anyway, it is, I think, a very useful sign in clinical practice and can be important in the emergency ward when there is not a lot of time to decide on therapeutic decisions. Sometimes echocardiography, and in this case here a transthoracic echocardiography, can show you the embolus, then it's easy. Then the diagnosis is done. Sometimes you also see emboli in the right atrium and in the left atrium. And this image shows that this embolus here is passing the PFO. And this indeed seems to be the case here. See, that's quite an extraordinary image, but it certainly generates a lot of clarity in terms of differential diagnosis. And even more so, that's a different patient who has bilateral pulmonary embolism. Echo can provide sometimes even more information and tell you what thrombus consists of. So this is a young patient, just 30 years old, who suffered from severe acute dyspnea. You see the McGonnell sign, but you also see this here, which is a tumor. And so it is it's in the right atrium, and it has many typical signs of a myxoma. It is attached to the Eustachian valve here. And seems to be very unstable, has very flotating parts. And indeed, it is a myxoma, and the embolic material retrieved from the pulmonary circulation was in major part from this tumor as well. So taken together, I think the echo is a very, very useful method when you have a patient with acute dyspnea. It should be applied early in the diagnostic process, after the clinical exam, the laboratory exam, the ECG, and eventually the X-ray. And you can use it for assessing cardiac function. It is a comprehensive assessment if you want. You can look at everything. And also it provides you a lot of help in terms of differential diagnosis, mainly whether there is the reason for the acute dyspnea is an intrinsic cardiac problem, or whether it is an aortic dissection, a pulmonary embolism, or something else afflicting cardiac function. Then, thank you very much.